we are back again with Med School Radio. And if you have not been listening, we have been talking about von Willebrand's disease. So this is continuing with our conversation about thrombosis and hemostasis. So let's continue. So let's remember that von Willebrand's factor is synthesized in endothelial cells and megakaryocytes, where von Willebrand's factor is stored in Weibel pallitate bodies and platelet A granules. Note that von Willebrand's factor is not synthesized in the liver, as are most of the coagulation proteins, and von Willebrand's factor serves two important functions as follows. First, von Willebrand's factor is the ligand that binds platelets to the damaged vessel wall through the GP1A receptor on platelets. And two, von Willebrand's factor carries and stabilizes coagulation factor 7, the anti-hemophilia factor in the bloodstream. Creating multimers of the correct size is essential for von Willebrand's factor to bind collagen exposed on denuded endothelium in the face of the shear forces in the circulation. In fact, multimers are unfolded in the circulation to accentuate their ability to bind platelets. The enzyme Adamantase 13 normally refines the size of the multimer so that their binding properties are just right. In the absence of Adamantase 13, the very large multimers characteristic of that disease bind too many platelets, thus creating aggregates that occlude vessels. Molecular variants of von Willebrand's disease. Type 1 von Willebrand's disease is the most common type of von Willebrand's disease, accounting for approximately 80% of patients. Type 1 von Willebrand's disease is caused by a partial quantitative deficiency of normal functioning of von Willebrand's factor. Type 3 von Willebrand's disease is not common. There are approximately 1% of von Willebrand's disease and is the result of almost complete absence of von Willebrand's factor because of a homozygous genetic defect. Type 2 von Willebrand's disease is the result of abnormalities in the protein synthesis of post-translational processing of von Willebrand's factor. Type 2 von Willebrand's disease represents a variant with a decrease in the proportion of large functional multimers, which results in decreased platelet adhesion aggregation. Type 2b von Willebrand's disease is caused by mutations that increase platelet von Willebrand's factor binding so that the concentration of functional von Willebrand's factor in the plasma is decreased. The mutation in type 2M VWD decreases or prevents von Willebrand's factor binding to platelet GP1A. Type 2 von Willebrand's disease is sometimes referred to as an autosomal recessive hemophilia because the mutations impair binding of von Willebrand's factor to factor 7, causing premature loss of factor 8. What are the clinical manifestations and diagnosis here? Mucosal bleeding characterizes von Willebrand's disease, which presents clinically as thrombocytopenic state because of the necessary collaboration between von Willebrand's factor and platelets. Of course, symptoms in type 1 partial deficiency are milder than type 3 or complete. This is the complete type deficiency of von Willebrand's factor. The family history can be very informative. The workup of von Willebrand's disease requires a sophisticated coagulation laboratory because it is necessary to measure von Willebrand's factor antigen, the presence of the protein, ristocytin cofactor activity in a platelet aggregation study, and factor 7 coagulation activity. Consultation with the coagulation laboratory can pinpoint evaluation. Multimer analysis requires considerable expertise. And now on to treatment. Desmopressin, which is one Desamino 8-D-arginine vasopressin, or DDAVP, is a synthetic form of the antidiuretic hormone that can trigger release of preformed von Willebrand factor from endothelial cells. Because patients with type 1 VWD produce decreased amounts of VWF, it is those patients who benefit most from the stimulatory effect on release of von Willebrand factor. DDAVP is not useful in types 2 and 3 von Willebrand disease. Factor replacement therapy provides viral attenuated plasma-derived von Willebrand factor concentrates with factor 7 to be administered intravenously. Cryoprecipitate is no longer accepted because of the risk of hepatitis and HIV infection. Fibrinolytic inhibitors such as epsilon aminocaproic acid and tranexamic acid are often used as a prophylactic therapy for operative dental procedures, which are, even in healthy individuals, attended by considerable bleeding. Now let's move on to talk about coagulation protein defects. First, hemophilia, factor 8 or factor 9 deficiency. Factor 8 anti-hemophilia factor is a large glycoprotein of 320 kD synthesized by hepatocytes, which circulates the plasma in a complex with von Willebrand factor. Factor 7 undergoes activation by factor 10A or thrombin, and the activated factor 8A is a cofactor, not an enzyme, that hastens the activation of factor 10 by factor 9A. Deficiency is inherited in an X-linked fashion and has an incidence of 1 in 500 male births. Queen Victoria passed on the mutant gene to several daughters, and as a consequence, the young Russian Tsar Evich was stricken with hemophilia before effective therapy was available. This led his parents to focus on his disease rather than the tumult in the nation. This disease thus played a contributory role in the Russian Revolution. A male inheriting an X chromosome having the defective gene hemizygote will suffer from hemophilia. If a female carrier mates with an unaffected male, 1/2 of the daughters will be carriers and 1/2 of the sons will be hemophiliacs. In a mating between a hemophiliac male and a non-female, no sons will be affected. Sons receive the paternal Y chromosome and maternal X chromosome, but all daughters will be obligate carriers. Notably, 30% of hemophilia cases are new mutations. It is speculated that because the gene for factor 8 is very large, 180,000 base pairs, there are many opportunities for mutations. Rarely, severe hemophilia due to factor 8 or 9 deficiency may occur in a female. This can occur with unequal lionization, with the defective allele being preferentially expressed. Hemophilia can also arise if a female carrier mates with a hemophiliac male or a female with Turner syndrome, which is XO. Turner syndrome is hemizygotes for the mutant gene. There is a wide range of mutations including single base substitutions, missense and nonsense, deletions, insertions, and inversions. Deficiency of factor 9 is the cause of hemophilia B. It is also called Christmas disease after a patient with the affliction. Clinical manifestations of both A and B are indistinguishable because both factors are involved in the formation of tenase XA's complex. Clinical manifestations. As noted, with hemophilia A and B, both hemophilia A and B produce a virtually identical clinical picture. Clinical severity is correlated with circulating levels of the relevant coagulation factor, with less than 1% of normal associated with severe disease. Individuals with severe hemophilia experience frequent spontaneous bleeding into joints, which is called hemarthrosis. Individuals with severe hemophilia also develop bleeding into soft tissues, which is called hematomas. These hematomas might dissect through tissue planes. Hemorrhage after trauma surgery is usual. Patients with moderate deficiency, 1 to 5% of normal, suffer hemorrhage secondary to trauma surgery or surgery, and rare episodes of spontaneous hemarthrosis, while the patients with mild deficiencies, 6 to 30% of normal, will have hemorrhage after surgery or trauma, but rarely will experience spontaneous hemarthrosis. Fetuses subjected to prolonged labor, forceps deliveries, or vacuum extractors are at risk for intracranial hemorrhage. Notably, only one-half of boys with severe hemophilia bleed excessively from circumcision. But if there is a family history of hemophilia, circumcision should be prescribed, which means that it should be avoided. The first spontaneous hemarthroses occur with severe hemophilia when the child starts ambulating and is moderately affected. Boys and it occurs with severe hemophilia when the child starts ambulating and in moderately affected boys 1 to 2 years later. The knees are the most common affected joints, and before factor replacement therapy suffer severe deformities. Elbows, ankles, shoulders, and hips follow in frequency. Acute hemarthrosis produce a tingling or burning sensation immediately recognizable to the seasoned patient and arise from the venous plexus beneath the synovium. Prompt replacement of the deficient clotting factor to the normal range, greater than 50%, can abort the bleeding and relieve the pain. For pain relief, aspirin and other drugs that exert powerful antiplatelet effects are contraindicated, as such drugs would only exacerbate the bleeding. Narcotic analgesics alone or in combination with acetaminophen are preferred. Treatment: prompt and adequate intravenous replacement of the missing factor to achieve hemostatic plasma levels is the most effective therapy, while patients wait for the breakthrough in gene replacement therapy. Home administration of the purified factor by management of a hemophilia center will provide optimal care for patients. Products free of viral contamination are of paramount importance because 90% of patients treated before 1985, when hepatitis testing was introduced, are seropositive. Even more disturbing, HIV contamination of pre-1985 blood and development of AIDS has become the leading cause of death in hemophiliacs, accounting for greater than 50% of all fatalities. Recombinant factor 8 and 9 concentrates do not transmit blood-borne pathogens and are preferred therapy. Recombinant factor 8 and 9 concentrates are expensive, but with routine use the number of complications is reduced, and so too is the overall cost of care. Another complication of factor replacement therapy is the development of alloantibody inhibitors, heralded by the lack of therapeutic effect in curtailing a bleeding episode. These antibodies are of the IgG class, and treating patients with antibodies requires considerable expertise. Now let's talk about vitamin K deficiency. Vitamin K functions as a coenzyme in the carboxylation of selected glutamic acid residues present in the procoagulant factors 2, which is prothrombin, 7, 9, and 10, and the anticoagulant factors protein C and S. Creation of a gamma carboxy glutamate residue deploys two negatively charged carboxylate groups adjacent to each other to build a positively charged calcium ion. The calcium-containing complex facilitates binding of these post-translationally modified proteins to negatively charged phospholipid surfaces. This greatly accelerates the rate of reaction in the coagulation pathway. The major sources of vitamin K are green and leafy vegetables. As a fat-soluble vitamin, vitamin K requires bile salts and is predominantly absorbed in the ileum. Intestinal bacteria also make a contribution to vitamin K production, but patients on broad-spectrum antibodies can develop a deficiency because of loss of this source, compounded by poor intake, especially in an ICU. And vitamin K deficiency can occur in infants, and oral prophylaxis has been shown to be effective. Vitamin K is usually administered in the immediate neonatal period to prevent development of hemorrhagic disease of the newborn. The PT is the test screening, a test for vitamin K deficiency. Supplemented with vitamin K levels when appropriate. A coagulation laboratory will be able to measure proteins induced in vitamin K absence, PIVKA, which are non-carboxylated forms of the proteins subject to vitamin K action. And talking about liver failure. Bleeding in patients with chronic liver disease and cirrhosis is often due to bleeding from esophageal varices caused by portal hypertension. This bleeding can be rapidly fatal. More subtle bleeding can occur because the liver is the site of production of all clotting factors except von Willebrand factor. In advanced parenchymal liver disease, there is impaired synthesis of these proteins, which is compounded by further impairment in the vitamin K-dependent carboxylation of the procoagulant factors 2, 7, 9, and 10, which is carried out in the liver. Further, because of splenomegaly and decreased thrombopoietin production by the liver, there is an increased destruction of platelets with counts between 50,000 and 100,000 per microliter. Fibrinogen levels are also decreased in patients with decompensated cirrhosis or acute liver failure. There is evidence that not only procoagulant proteins are decreased in advanced liver disease, but so too are anticoagulant proteins. While the balance between these in any patients is precarious, some patients with severe liver disease are prone to the development of thrombi. The PT is probably the best readily available test to document a coagulopathy in liver disease, but some have advocated thrombin generation test as more indicative of the tendency to bleed in such patients. Fresh frozen plasma, or FFP, treated to destroy potential blood-borne pathogens is the most effective treatment to repair the coagulopathy. In some patients, vitamin K may be useful as well, but as liver disease progresses, vitamin K will no longer be therapeutic because the enzyme systems in the liver have been badly damaged.